India. So the title for my talk for today is Use of intraovarian platelet-rich plasma does not increase the ovarian reserve markers, ovarian response or IVF outcome in Bologna poor responders. I have no potential conflict of interest to disclose. The poor responders constitute a significant percentage of IVF cases worldwide, and physiological or pathological reduction in the ovarian reserve appears irreversible, leading to high risk of cycle cancellation, low number of oocytes or embryos, and very low pregnancy rates. Now, why is this study relevant? Now, management options of poor responders are plenty, but there is no definite evidence of benefit for any of them. The ideal number of oocytes after ovarian stimulation, the best outcome comes for after an average of 10 to 15 oocytes, and here is where the poor responders lag behind. So the options available for them include IVF with autologous gametes, donor gametes, or an adoption. So how can intraovarian PRP help in poor ovarian response? Now, there is a renewable ovarian germline stem cells which exist in the ovaries. And also there are progenital stem cells in the blood which can either be of hematopoietic lineage, which may promote angiogenesis, or non-hematopoietic lineage, which could differentiate into mesenchymal cells. The study question which we posed was, does administration of autologous intraovarian PRP, that is IOPRP, increase the ovarian response reserve markers, ovarian response, or IVF outcome in Bologna poor responders? This was a pilot study to assess the feasibility and adverse reactions following IOPRP for a full-fledged RCT. So briefly, coming to materials and methods, when a couple had a failed IVF with POR as per Bologna criteria, and they had AMH and AFC within the last 3 months, they underwent a recruitment and a counseling session. Followed by that, the patients who agreed and who fulfilled the criteria, they underwent the intraovarian PRP procedure, and then after 2 months, we repeated the AMH AFC, that is the ovarian reserve markers, and we did the IVF after 2 months, and then we compared the pre-PRP versus and the post-PRP values, and then we came to a conclusion whether there is any help from the IOPRP or not. So it was a prospective observational cohort pilot study done for 18 months duration at Kraft Hospital Research Center, Kerala, India. There were 30 POR reproductive age women diagnosed with Bologna criteria, and they were recruited after the internal ethical committee approval and after detailed counseling regarding the experimental nature of the procedure. The inclusion criteria included POR as diagnosed by Bologna criteria, the last IVF with POR being within 12 months of recruitment so that we can compare the ovarian reserve parameters better. Details of previously performed ovarian reserve testing available within the last 3 months of recruitment, and the ladies who had regular cycles. The exclusion criteria included peri and postmenopausal women with basal FSH of more than 20, absence of one ovary, severe male factors of fertility, diffuse adenomyosis, and thin endometrium in previous stimulation cycles. Coming to the PRP preparation, the IOPRP was performed in the mid-late follicular phase, and before taking the sample, we gave the GCSF, that is granulocyte colony stimulating factor 300 microgram for 3 days subcutaneously. This was to increase the number of blood cells. The technique of the PRP preparation which we followed was standardized with the FDA-approved commercially available kit, that is a Reagan PRP kit. And for all patients, a baseline complete blood count was done, which was repeated after 3 days of systemic GCSF. And WBC concentration increased to a range of 24,000 to 37,000 cells per CUMM. So we took 20 ml of the blood in the acid-citrated dextrose solution gel tube, which contained all the elements, that is RBCs, WBCs, platelets, and plasma. And then the first centrifugation was done at 3,500 RPM for 15 minutes, which led to the RBC settling at the bottom because of their heavy size. The plasma, that is the platelet, poor plasma at the top, and in between was the layer containing platelets and WBCs. Now the layer of platelets and WBCs was then taken for the second centrifugation, which was done at 1500 RPM for 10 minutes. And the final sample, this contained this particular layer, that is platelets plus WBC, and the platelet poor plasma was added to make up to a total volume of 4 ml. Then this particular solution, this particular volume was divided into 2 aliquots of 2 ml each, and the activation of PRP was done by freeze-thaw technique using the liquid nitrogen. Post-PRP, the platelet count was checked, which rose to a range of 10 to 30 lakhs per microliter, and PRP was instilled within 30 minutes of preparation. Coming to the injection details, the injection was performed using 17-gauge double lumen needle under conscious sedation and ultrasound guidance. The ovary was aligned with the needle guide. The needle was advanced into ovarian stroma at a depth of 5 to 10 mm from the ovarian cortical surface under ultrasound guidance. And once the tip placement was confirmed, 1 ml of activated PRP sample was introduced by slow push injection as the needle was slowly withdrawn up to just underneath the outer cortex. The needle was then reinserted into another site by redirecting the needle, and another 1 ml of sample was instilled. That is, we injected at 2 different sites. An ultrasound assessment was performed to ensure vascular integrity and absence of excessive pelvic fluid, as is done after IVF oocyte retrieval. And after the procedure, the patient was asked to rest for 15 minutes and vital signs were monitored for 1 hour post-procedure. Complete hemogram and ultrasound pelvis was done at post-procedure day 1 and was repeated 1 week to ensure there is no complication. 2 months post-PRP, on the cycle day 2, we checked the AMH, FSH, estradiol, and AFC. And stimulation was started on the same day with flexible antagonist protocol with 225 to 300 units of gonadotrophins. Trigger was given at lead follicle of 18 millimeter size with recombinant HCG of 250 micrograms. ICSI was the insemination technique. The embryo quality was assessed by Istanbul consensus. The embryo transfer was done on day 3. Vaginal micronized progesterone 400 micrograms BD was used for the luteal phase support. Beta HCG was checked 15 days after the post-ICSI day, and transvaginal scan was done for clinical pregnancy 4 weeks after the embryo transfer. Statistical analysis was done by SPSS, and the means were compared. Comparison of mean was done by independent sample t-test and chi-square test. The results were following. The age of the patient, the mean age was 38.7, BMI 24.7, number of attempt 2.33 prior to the PRP in installation. Duration of infertility was 6.3 years. Coming to the ovarian reserve testing, that is AFC and AMH. So the orange bar shows the pre-PRP and the red one shows the post-PRP. So both AMH and the AFC, pre and post-PRP, there was no difference. That is, p-value was non-significant. Similarly, for FSH and estradiol, pre and post-PRP, there was no difference between the 2 parameters. Coming to the COS outcome, that is dose of gonadotrophin and estradiol level on the trigger day, the pre and post-PRP levels showed no difference. So both the groups, that is pre and post-PRP, have similar dose of gonadotrophin estradiol level. Same thing was for the number of days of gonadotrophin and the number of optimal follicles more than equal to 14 millimeter. They were also similar in both the groups. Coming to the ICSI outcome, that is the number of M2 oocytes, FERT rate, day 3 good embryos, and the number of embryo transferred. Between the pre and post PRP groups, all these parameters were similar. So there was no difference in any of these parameters between the 2 groups. So out of total of 30 women, 5 women, that is 16.6, had cycle cancelled due to lack of follicular growth. 3 women, that is 10%, had ET cancelled as they did not have any embryos to be transferred. And embryo transfer was performed in total of 22 women. So clinical pregnancy was 13.3%, that is 4 out of 30, and live birth rate was 10%, that is 3 out of 10. The adverse effect, the immediate post-procedural pain in the lower abdomen was the commonest symptom and seen in all women, which settled within few hours. None of the women had fever, pelvic inflammatory disease symptoms, allergic reactions, hemorrhagic complications, or persistent post-procedural pain. Coming to the discussion, this study focused on Bologna poor responders and evaluated the effect of IOPRP on reproductive outcome up to the live birth rate. The published research in IOPRP is limited to case series and small retrospective studies with no proper RCTs being conducted. And IOPRP is still used by many centers without any evidence of benefit. This was one of the earliest studies which was presented as a ISHRE abstract, but here no embryo transfer was done in this particular study. So that was not evaluated. Then there were a few more studies. One of them even said that the chromosomal error can be corrected, but they have their own conflict of interest. Limitation of the study includes, it's an observational cohort study. Women served as their own historical control. It had a small sample size. We cannot comment if waiting beyond 2 months would have changed the outcome. And quantification of specific platelet-derived growth factor was not performed. So whether level of a particular factor beyond the specific threshold can have a beneficial effect was not studied. Conclusion, autologous intraovarian PRP has not been shown to improve the AMH, AFC, ovarian response or IVF outcome, and it should be restricted strictly to the research setting till evidence to the contrary. Thank you for your patience here.